Really looking forward to hear from our guest of honor. That's Dr. P Paily, who's MD FRCOG. He's the past president of Kerala Federation of Obstetrics and Gynecology, state coordinator of the confidential review of maternal deaths in Kerala. And he's a consultant, Rajagiri Hospital, Lallu, Ernakulam district, Kerala. Sir has published in various national, international journals, edited and published the Obstetric Management Protocol, edited and published Why Mothers Die, that's in Kerala 2004 and 2005, edited and published the Handbook of CHC Obstetric Upgradation Project, Kerala. So over to you, sir. We look forward to hear from you your experiences with the confidential review of maternal deaths in Kerala.
Thank you very much. Thank you, Dr. Lallu, Dr. Vijay Agarwal, and all our friends over there. And thanks to Kaho for this opportunity to share the podium with you. I have been asked to briefly review the way we have been doing the maternal death audit in Kerala. I'm very glad to announce that as of last year, we have been able to achieve an MMR of 30, under 30 per 100,000. And we believe that at least partially it is due to the way we have been auditing maternal deaths and acting on it. So that is why I thought I will share our experience of doing this, whether we can actually use this for the theme of the day, and that is patient safety, especially related to maternal and newborn health. And that's exactly what our purpose was. And safe maternal and newborn care, our strategy in Kerala was to use audit as a means of doing that. And not just audit, but act on the findings, find out remedial measures and implement them. So that is what we were doing. As all of you know, there are different types of audit. And the ones that are usually mentioned, and this is very clearly written in some of the WHO textbooks, and the ones are of the highest order is confidential review of maternal deaths. There is the near-miss audit, there's a facility-based audit, and verbal autopsy. To that, we would add one more, and that is a morning report. What we have been practicing is for the last, in fact, we started it in 2000, at the beginning of the century. What we mean by this is very simple. People attending the labor room and the rest of the staff in the department, preferably all staff, to attend for a very short time, maybe 15, 20 minutes or even 30 minutes every day in the morning, just to recall what happened the previous day and what's the plan for the day. We should use that opportunity to appreciate the good points and also to correct if there have been any shortcomings. But reprimand should not be the order. We find that this is the most effective way of auditing things because the event is fresh in our mind. And if it is conducted in such a way that there's no fault finding, then everybody will be happy to join it. Then let me take you through our journey, and that is confidential review of maternal deaths in Kerala. We started this in 2004 with full support from Government of Kerala. I should admit that it was WHO which helped us to start off this process. After I attended a workshop in Delhi organized by Southeast Asia Regional Office of the WHO, and thereafter WHO supported us to start the audit. In fact, all the Southeast Asian countries were there in that workshop, and I think ours is the only state which started to do it. KFOG from its inception, that is the Kerala Federation, from its inception had pledged to bring down the maternal mortality in our state. And the Maternal Fetal Medicine Committee of the Federation took up the responsibility of doing that. And as I said, we could achieve what we were aiming for because the government of Kerala with Kerala Federation had declared a target of achieving 2030 by 2020 a target of 30. And we at the moment are working with a target of achieving MMR of 20 by the year 2030. Remember, that's the time when Government of India is planning to achieve an MMR of 70. In the government order of Kerala, KFOG, our federation, has been recognized as a technical support partner. How can KFOG do? What can KFOG do to achieve this goal? That is what we were looking for. But we were very aware of the fact that the federation or the professionals like us could not do that by ourselves. And that applies to any nation, any state. We should get the support from the politicians, the administration, the patient and family, the society at large, nurses, midwives, and of course other branches of medicine. And what we did in our state was the Kerala Federation of Obstetricians and Gynecologists got together, and we got the support from the government as well as other non-obstetrician colleagues who were very much supportive of our activities. But all of you know that it is very difficult to audit, especially a maternal death, because everyone is suspicious of the other. That is a fact. What we realize, and I'm sure you also will agree, the more the IQ of the people involved, the more difficult to work together. Everybody will be suspicious of the other. And especially when a calamity has occurred like a maternal death, we cannot reveal all the details or the facts because we are worried that others will do something to torpedo your status. Why did we start? Because we had pledged to work to bring down the maternal deaths. But we knew that to work properly, we should know why the mothers die, how many of them die, and also what steps will help to avoid those deaths. And that is the very purpose of the audit. But one thing we were very convinced is that the truth of the death and the circumstances will come out only when it is audited anonymously and only when it is guaranteed that there is no punishment, even if some shortcoming is revealed. And that's the basic principle of confidential review of maternal death. As all of you may know, the British started it in 1952. And the principle they followed was no name, no blame. And that is why they called it the confidential inquiry into maternal deaths. We thought we'll change it to differently because inquiry immediately brings this fear complex. Inquiry, some punishment will follow. So that is why we called it confidential review of maternal deaths. We published our findings in the name of Why Mothers Die. The first 2 editions came out, the second one in 2012, and the third edition covering the last 10 years is now ready for publication. The real strength of our activities was the large number of voluntary associates, obstetricians and non-obstetricians who helped us. Later on, we found that we should probably expand this to not only deaths, but to near misses. And that was the trend across the world, as you know. A near miss review also can be done in a confidential manner. In other words, without revealing the identity of the patient or the treating doctor. Later on, we found that it is not enough. The whole state does it as a centralized job. We thought that we have to decentralize it. And that is how we started what we call MDNMSR. That tongue twister is actually standing for maternal death and near miss surveillance and response. The surveillance and response is the key factor. Whether you audit death or near misses or whatever it is, once you identify by surveillance, you should respond to it by action. And that's a basic principle which was brought out by WHO in 2004 and 2002, and that is what we took up. In MD and MSR, at the district level, the obstetricians come together. The meeting is convened by the reproductive and child health officer, that's the RCH officer. The collector of the district or the district medical officer will be chairing, and of course, all obstetricians will take part. And here we will just anonymously find out what deaths happened in the districts in the previous month, but discuss in detail near-miss cases from the various hospitals so that we can learn lessons from it. All the peripheral health workers will be invited to attend it. And as I said earlier, the important thing is not only the surveillance or finding out what happened, but to act on it. And the idea was to find out why they died, and if there are avoidable causes, what can be done to avoid that happening again, and to develop strategies. And we found out that PPH was still the #1 killer. And so we worked on methods to overcome PPH and then avoid that. So active management of third stage of labor and proper observation in the fourth stage of labor was found to be important. And in addition, we developed methods to arrest the bleeding immediately, like the transvaginal urinary clamp or a suction cannula to be put in the uterine cavity, which can stop the bleeding. We had to train our PGs and obstetricians in the periphery how we can stop bleeding. Surgical procedures like modified B-Lynch or stepwise devascularization, internal iliac ligation, etc. So this is what I meant by surveillance or finding out why they died and the response as to what we can do to avoid that happening again. We found that the #2 cause was hypertension. So we brought out guidelines as to how to address this issue of hypertension as a cause of maternal death. At what level of hypertension we should start treatment? What drug should be used? Like that. How magnesium sulfate should be promoted for impending eclampsia as well as eclampsia. We found that amniotic fluid embolism was a cause, and one of the leading reasons for that was using prostaglandins leading to hyperstimulation. So we advised how much to use, how to use it. In addition, we found that in some centers, they were using smooth muscle relaxants like epidocin, rotavirin to hasten the last stages of labor. We went out banning that, saying that once the woman is in established labor, no more smooth muscle relaxants, because that can also lead to amniotic fluid embolism. We promoted and demonstrated with mannequins how perimortem cesareans can be done. We went out to promote aseptic practices, proper waste disposal, and proper use of antibiotics to prevent sepsis, which was another leading cause of maternal death. Pulmonary embolism, not as much of a problem as the others, but still a major problem. And so we avoided enforced bed rest, encouraged early ambulation and fluid intake, and used thromboprophylaxis, especially after cesarean, more liberally. And we also found that there should be a proper way to manage when obstetric emergencies happen, and emergency obstetric care and life support was promoted, and we trained the obstetricians, not only in the central parts, but in the periphery also, how to provide emergency obstetric care and life support to the patient who is in emergency. And the government also agreed to support it. In 2013, NICE International came to collaborate with us, and we stretched out the suggestions that we already heard in the name of quality standards. And with their support, we crystallized the way active management of third stage should be, the way hypertension should be managed. And that also helped us to address the issue. But then we found that if there is an emergency in the hospital, big or small, sometimes it may be only the nurse who is there on the spot. Others may be coming, but after a while, and that will be too late. So we came out with the suggestion that there should be obstetric rapid response team wherever delivery occurs. That team doesn't need very highly trained people, at least a nurse who can have vascular access, who can give basic life support is enough. So such a trained person should be available under the roof, not to come from home 24 hours a day, wherever there is delivery taking place. So a scheme like that was started, and that is what we call obstetric rapid response team. Each hospital should have a pool of trained personnel. At least one of them should be available round the clock. And of course, there should be a mechanism to call such a person. And mobile technology being available now, we thought we can use that to call the people. And the training of such people should include ability to have vascular access, including intraosseous fluid administration, of course, CPR, and the steps to arrest bleeding like that. So this is not a substitute for emergency obstetric care and life support, but at least as a first aid, there should be somebody, because we know that in obstetric emergencies, time is the most critical element. If we act immediately and promptly, the emergency may not even continue, but otherwise it will go on to a near miss and to a death. We have to ensure minimum standards of the delivery points. And that is why with the government of Kerala, we said that we should have accreditation of the obstetric units. These were the steps as a result of the audit that we found, which will help to address the issue of maternal deaths in our state. We declared a strategy of zero tolerance to avoidable maternal deaths, but it needs a comprehensive approach with involvement of not only the obstetricians, all our paramedical staff, nurse midwives, administrators, politicians, and of course the government. And that was our plan. That is what we found out, and we are sure that probably this is a way that others can adopt in their chase to bring down maternal deaths. Thank you very much.
Brilliant, brilliant presentation, sir. We've heard lots, and I was really looking forward to hearing this session. Wonderful work done, and congratulations to you, the entire team, and the state of Kerala for doing this wonderful job. It must have been very challenging, I'm sure, and it's now 10 years down the line, or 20 years. Am I right?
Yeah, it's 2004 we started.
Yeah. So now I'm sure when you look back at all the challenging years, now you must be feeling really happy that things have moved on and the kind of culture that is set in. And it's very, very interesting to hear your talk, sir. I really appreciate Raju.
You are very right, Lallu. I mean, that is the important thing. It is, as the WHO also says, it's a discipline. It's a mindset. And once you feel that audit is the way that is possible, it's acceptable to our colleagues, then it will move forward. And that is how, from the maternal death audit like that, we moved on to, as I told you, decentralizing it to the district headquarters. And that is very enthusiastically taken by our obstetric colleagues in the periphery. An occasion to come together, discuss their problem cases every month. And when there is confidentiality, that people will not hesitate to come out with the facts. That is what we found out. Thank you very much.
Thank you. Thank you.